Let's talk about opiate abuse in pregnancy. There's a sharp increase in neonatal abstinence syndrome. 6 out of 1,000 hospitalized births in 2013. Opiate use disorder pattern of opiate use characterized by tolerance, craving, inability to control use, continue use despite adverse consequences. DSM-5 outlines 11 main symptoms of opiate use. If you have 2 or 3, it's mild. If you have 4 to 5, it's moderate. And if you have 6 or more, it's severe. So the role of OB is to do a spurt screening, brief intervention, and referral to treatment. Physiology: heroin is a rapid-acting opioid. Withdrawal symptoms starts within 4 to 6 hours of use, peak at 1 to 3 days. Methadone withdrawal within 36 hours, last weeks. Risk of overdose, respiratory depression, and death is greater with full agonist. Withdrawal symptoms are rarely associated with severe morbidity. Withdrawal symptoms include generalized pain, muscle pain, nausea, vomiting, sweating, rhinorrhea, tearing, dilated pupils, tremor, goose flesh, restlessness, anxiety. Effects on pregnancy: there's a small increased risk for birth defects. Untreated heroin usually is related to lack of prenatal care, risk of FGR, placental abruption, fetal death, preterm labor, meconium, co-occurring mental health issues such as depression, PTSD, and anxiety. Screening: you generally recommend universal screening with the 4 P's: parents, partner, past and present. There are NIDA quick screens, National Institute of for Drug Abuse, craft questions for 26 years or younger. 2 or more is a positive screen. Questions asked in craft is car, relax, alone, forget, family, trouble. So what do they mean? Have you ever ridden in a car driven by someone who was high? Do you ever use drug or alcohol to relax, feel better about yourself, or fit in? Do you ever use alcohol or drugs while you're alone? Do you ever forget things while using alcohol or drugs? Do your family or friends ever tell you that you should cut down on your drinking or drug use? And do you ever get in trouble for using alcohol or drugs? Treatment: methadone. There is a significant pharmacokinetic interaction with antiviral drugs, antiretroviral drugs, so heart, and prolonged QT interval may need to increase dose, especially in third trimester, can only be distributed by certified treatment programs. Lower dose is not associated with milder or shorter um, neonatal abstinence syndrome. Buprenorphine or Subutex has fewer drug interactions and is a partial agonist, can be prescribed by any DEA without need for daily visits, less need for dosage adjustment during pregnancy. It does lack pregnancy data, rare report of hepatic dysfunction, increased risk for diversion, sharing, or sale with mono products. So mono product versus combined formulation with naloxone, which is a antagonist. It can cause severe withdrawal symptom when injected. Combination product decreases risk of misuse. There is a risk for precipitated withdrawal when switching from buprenorphine to methadone, but not the other way around, I think. So only from Subutex to methadone. Medically supervised withdrawal has high relapse rate and poor outcome. Naltrexone is a this is combined therapy with naloxone, not naltrexone. It's a opioid receptor antagonist, blocks the euphoric effects, help non-pregnant patients with opioid use disorder in their effort to maintain abstinence. Unknown fetal effects. Naloxone is a short-acting opiate antagonist given for opiate overdose. Can be given during pregnancy to save life. Can be done IV or sub-Q. Antepartum. These patients should get STD testing, screening for mental health and other substance abuse, Hep B vaccine, contraception discussion, intrapartum, continue maintenance dose. Do not give agonist-antagonist drugs such as butorphanol, nalbuphine. This is Nuban, I think. Pentazocine. Don't give buprenorphine if taking methadone. Requires 50% more opioid analgesic during intrapartum. Postpartum transfer of methadone or buprenorphine to breast milk is minimal. Breastfeeding is not recommended when using meds with codeine or tramadol. Methadone dose might need to be lowered. Relapse more common in postpartum. Postpartum depression screen should be done. Neonatal abstinence syndrome. The baby can have GI autonomic CNS effects with irritability, high-pitched cry, poor sleep, uncoordinated sucking reflexes, and poor feeding. Usually occurs within 3 days, may begin anytime within the 2 weeks of life, resolved by 7 days. Seen in 80% of infants with opioid abuse. We can use the Finnegan score to score these infants.